ASAN Network. I am your Dr.Salauddin, MBBS MS Orthopaedics, and welcome to our fracture classification series. This is the second video in this series, and we are discussing the second bone of our fracture classification series, that is the humerus bone. So, we are going to discuss the humerus fracture classifications, and we are going to divide the humerus into three parts, that is the proximal humerus part. So we'll discuss the proximal humerus fractures first, then comes the shaft fractures or the diaphyseal fractures, and the distal humerus fracture classification. So we'll deal with each of these classifications individually. So let's start with our proximal humerus fractures. So the proximal humerus fracture, the first proximal humerus anatomy, there are four main parts in the proximal humerus: the head, the greater tuberosity, the lesser tuberosity, and the shaft. So how this fractures is, it fractures into individual parts, that is the head gets separated, the shaft, the lesser tuberosity, and the greater tuberosity, they separate and fracture individually. It happens because of their muscle attachments. Okay. So how do you classify these fractures? We have four classification systems for the proximal humerus. The first, starting with the Codman's classification, then the most commonly and clinically used classification, that is the Neer's classification, and the universal AVO classification, and the latest binary or LIGO classification, which was given by Hertel et al. So we will discuss individually each of these proximal humerus fracture classifications. So coming to Codman's classification, it's a very simple classification. As I have told you, four parts of the proximal humerus. He gives a permutation of these fracture classifications, that is the head, the greater tuberosity, the lesser tuberosity, and the shaft. They may be fractured individually or in combination to each other. So this is simple Codman's classification. The drawback with this classification is he doesn't speak much about the clinical relevance of these parts. Okay, we'll discuss first the universal AVO classification, and then we will go to the Neer's classification. So the AVO classification system, this is the AVO numbering of individual bones in the body. So the humerus is the first bone according to the AVO classification. So it is given the number 1. Okay, so the whole of the humerus is given as the number 1. As I have told you in the previous video, that AVO classification is an alphanumerical classification. So the number is for the bone and alphabetical order is given for the individual part of the bone. So the proximal part of the humerus is the first part of humerus. So he gives us 1, 1. The shaft is 1, 2, and the distal humerus is 1, 3. So the humerus is the bone 1. 1, 1 is for proximal humerus, 1, 2 is for the shaft, and 1, 3 is for the distal humerus. So coming to 1, 1, that is the proximal humerus fracture, is again divided into A, B, and C. So A is so in the previous lecture also I have told you, any AVO classification at the joint, they classify it as whether the fracture is outside the joint, whether it is involving partially or completely. So simply in simple manner, so any bone that is near the joint, they classify it as extra-articular, partial articular, or intra-articular fracture. So here 1, 1A is extra-articular unifocal fracture, 1, 1B is extra-articular bifocal fracture, and 1, 1C is articular fracture. Giving it as a parts, only the greater tuberosity is fractured, or the fracture is only at the one anatomical neck or the surgical neck. It is a unifocal fracture or a two-part fracture. If one tuberosity is fractured, the head is separated and the shaft is separated, it is a three-part fracture. Four-part fracture where all the parts are separated. Okay, so we will deal individually 1, 1A first. So the extra-articular unifocal fracture, 1, 1A is again divided into three parts: 1, 1A1, 1, 1A2, 1, 1A3. Simple. 1, 1A1 is avulsion fracture. So only the greater tuberosity is avulsed. 1, 1A1. Simple. 1, 1A2 is impacted metaphyseal fracture. So the fracture line is at the surgical neck and it is impacted into the shaft. 11A3 is, it is a non-impacted metaphyseal fracture, that is, it is displaced fracture. In other sense, it is displaced fracture. So it is 11A3. Coming to extra-articular bifocal fracture, 11B is again divided into 3, 11B1, B2, B3. So 11B1 is metaphyseal impaction. The two parts that are impacted into the metaphysis. Without metaphyseal impaction or displacement is B2, 11B2. And if there is a glenohumeral dislocation associated, then it is 11B3. So this is extra-articular bifocal 11B. Coming to articular 11C fractures, they are again divided into 3, that is the articular fracture with displacement and impacted valgus fracture, that is 11C1. So 11C1 is displacement with impaction. Then impaction with marked displacement. 11C1 is, so it is a valgus impacted fracture. 11C2 is with impaction and displacement. 3 is with glenohumeral dislocation. So 11C3 is glenohumeral dislocation. This is the AO classification system. So this is a clinical X-ray in the clinical setting. How do you classify this with the AO system? So let's see how is the fracture line and how many parts are there. So the fracture line in the X-ray is at the surgical neck. Yes, you are right, that it is the fracture line is at the surgical neck. And whether there is any impaction? No, there is no impaction. Okay, so whether the fracture line is articular or extra-articular or articular, the fracture line is extra-articular and it is at the surgical neck. And parts is only the head surgical neck fracture and it is a unifocal fracture. So the AO system, it comes extra-articular as 11A. Unifocal means 11A. How do you classify A1, A2, A3? Based on the impaction. So here it is not impacted. So AO 11A2. Simple. Coming to Neer's classification, he divides the proximal humerus into individual parts. Clinical importance of Neer's classification is that he given criteria for calling a part for individual fragments. So when do you call a part in Neer's classification? When the displacement of the fracture fragments is more than 1 centimeter, we call it as a part, and the angle between the two fracture fragments should be more than 45 degrees. So displacement and angulation, then if it is more than 1 centimeter and more than 45 degrees, then we call it as a part. So simply Neer gave their given criteria and he divided them into, so this is the classification: 1 part, 2 part, 3 part and 4 part fracture with a special type of fracture dislocation fracture. So 1 part is simply undisplaced fracture. There is no displacement and no angulation regardless of the fracture lines. How many number of fracture lines may be there, but if there is no displacement and angulation, you still call it as a 1 part fracture. If you want to call it as a 2 part fracture, there should be fracture line and the fracture should be displaced more than 1 centimeter either at the anatomical neck or the surgical neck, or the tuberosity should be fractured and displaced more than 1 centimeter. So 3 part fracture is the displacement of the fracture occurring at the surgical neck with fracture of the either the greater tuberosity or the lesser tuberosity. Either of the tuberosity should be fractured and displaced, and there should be a fracture at the surgical neck with displacement more than 1 centimeter. This is a 3 part fracture. So 4 part fracture is all the parts, 4 parts, that is the head of the humerus, the surgical neck, greater tuberosity and the lesser tuberosity. All these should be displaced more than 1 centimeter. So then we call it as a 4 part fracture. The special type is fracture dislocation. So here in the image you can see without any displacement, how many number of fracture lines? It is still a 1 part fracture. if there is displacement based on the number of fracture lines. Whether the fracture is at the anatomical neck or the surgical neck or lesser tuberosity or the greater tuberosity, we give it as 2-part, 3-part or 4-part fracture. And the special type is if there is any fracture with dislocation, it is fracture dislocation that is occurring anteriorly or it can occur posteriorly. This is Neer's 4-part classification. So how do you classify in the clinical setting? The same image of the AO here. According to Neer's, the fracture line is at the surgical neck. So whether there is a displacement, yes, there is displacement more than 1 centimeter, and whether there is an angulation, yes, there is more than 45 degrees of angulation. Only one fracture line at the surgical neck is there, and it is 2-part fracture. Okay, coming to binary classification, which was given by Hertel et al. So binary or the LEGO system, it means it uses the system as yes or no, like an LEGO assembling or disassembling block. So this is important in the clinical setting because it describes the fracture morphology using 12 basic fragments, combination of all the 12 basic fragments, and this will help in assessing the vascular risk, the avascular necrosis of the humeral head risk, and it also guides in the surgical planning. So what are the 12 fragments? The key 12 fragments, the 4 fragments we already know, that is the head, the shaft, greater tuberosity and the lesser tuberosity. Now he adds the medial hinge, that is here is the medial hinge, the lateral cortex, then the posterior-medial calcar. The posterior-medial calcar will be behind this, and the anterior calcar, and the surgical neck, the anatomical neck, and epiphyseal split and head displacement. These are the 12 fragments which he is talking about, and these are used for assessing the avascular necrosis of the humeral head. Okay, so in a simplified format, this is the table. By seeing an proximal humerus fracture X-ray, we ask these questions in a binary fashion, yes or no fashion, whether the medial hinge is intact. If it is yes or no, if it is yes, the medial hinge is intact, then the head may be stable. If it is not intact, then the head is stable. If the head split is present, there is high risk of avascular necrosis. The displacement of tuberosities are present, then the rotator cuff function is affected. If the posteromedial hinge or the posteromedial head is extended less than 8 mm, then there is a poor perfusion of the humeral head. And metaphyseal extension is less than 8 mm, then there is a high risk of avascular necrosis. And if there is a glenohumeral dislocation, then it indicates an severe trauma. This is a simplified format for the binary assessment criteria or the binary classification. So we will come back to the same X-ray that we have seen in the AO classification and the Neer's. So this is the same X-ray. Now ask the same questions that I have given in the binary criteria. So is the medial hinge intact? Here the medial hinge is intact. If it is intact, head may be stable. If the head split is present, is the head split present? No, the head split is not present, so there is a low risk of avascular necrosis. And if there is displacement of the greater tuberosity or the lesser tuberosity, the greater tuberosity is fractured and little displaced, so it may affect the rotator cuff function. And posteromedial head extension is present? No, then the perfusion of the head is good. If the metaphyseal extension is less than 8 mm, yes, there is no metaphyseal extension, so there is low risk of avascular necrosis. If there is any glenohumeral dislocation, yes, the head has dislocated, there is a glenohumeral dislocation, and this indicates an severe trauma. So binary the classification is useful in the clinical settings because it predicts the humeral head ischemia or the avascular necrosis criteria in high accuracy. It aids in deciding whether we have to do an osteosynthesis for the proximal humerus fracture or we have to do an prosthetic replacement by using this criteria. It emphasizes the vascular risk over just a fragment count, unlike a Neer's classification. Neer's only gives number of fragment counts, okay, but here he talks about the medial hinge and avascular necrosis criteria is predicted. This is another clinical X-ray. So comment in the comment section below which type of Neers is it, which type of AO classification comes it, and how much is the risk of AVN in binary according to binary classification. So thank you friends, please like, share and subscribe to my ASAN Net. It helps me in creating more videos. We'll discuss the shaft fractures in the next video. Thank you all.